What is recovery management checkup? It's a chronic disease management approach to addiction. It consists of personalized, long-term, typically 12 to 4 years, monitoring, early intervention and reintervention. And the goals are to detect needs and relapse. We want to shorten the time to treatment entry and reentry if as needed, and to improve thereby long-term outcomes. Relative to services as usual, RMC across these studies is associated with higher rates of initiating care, reduced time between relapse and readmission, higher rates of engagement using the federal definition of 2+ sessions in the first 30 days, and continuity of care, that is, if they stayed in care 90 or more days. So what are the specific components? That we use this acronym LIFT UP, which is the idea of the linkage manager. They are the central focus of the intervention, the active ingredient. These are dedicated guides to support treatment linkage and recovery journeys. They typically have a minimum of a high school equivalent education. Some of them have BAs or masters. The approach is guided by individualized computer-based script, or what we call a worksheet, that helps you combine the information that you have from the interviews, what's happening during the linkage session, and guide sort of some of the next steps. They use it to develop personalized linkage plans, to schedule and facilitate appointments, to ensure engagement, that we don't just take them to the door of intake. We want to make sure they stay, and provide continuous support throughout the recovery process. And when needed, they relink them to treatment. If they've dropped out or they've had a period of recovery but then have relapsed, we'll try to get them back in as fast as possible. It's a big difference to have somebody in your corner. The approach includes motivational interviewing, commitment to change, risk reduction strategies, consistent long-term supportive relationships. We'll meet them wherever they're at and try to get them to go along that continuum. But part of what these guys are doing is inspiring and sustaining the patient's, participants' recovery goals. They're staying in the life, they're staying in the game. A lot of treatments only 12 weeks or less. These guys are staying with them for 1 to 4 years.
I'm switching to talk more about a primary care-based study in what we call RMC-PC, or Recovery Management Checkups for Primary Care. Many people are in contact with a primary care provider who they may be seeing at least annually. And if we can implement procedures to identify potential substance misuse and have an intervention to get people into treatment, primary care settings can be really powerful for that. So the way this has been done traditionally is through something called screening, brief intervention, and referral to treatment, or SBIRT, which involves implementing some sort of basic, very simple, usually 3 questions, 4 questions that get at, is someone potentially misusing substances? If those get flagged, we would then have a little bit longer instrument that would help to understand if that patient, at what level that misuse might be at. Is it a mild, moderate, or potentially very serious misuse? And then from that point, if it's mild, they're going to hopefully be getting a brief intervention on the spot that's typically MI directed, motivational interviewing, and that's going to help to get them hopefully to see how their behaviors might be impacting their health, and begin to think about making changes. However, for individuals who might have a little bit more serious substance misuse issues, then we would want to move on to referring them to treatment. And when we're referring people to treatment, we know that this is the part of SBIRT that has typically fallen flat, particularly for individuals who are struggling with substance misuse other than alcohol. This is because typically those referral processes are very passive. No one's following up. No one is treating this as the chronic health issue that John's description shows that it really is. So what we wanted to know is, could we take an intervention that's rooted in this long-term model of supporting individuals and add that to the SBIRT model to help close that gap?
To put this in this broader perspective, so the first wave of our research was trying to establish the effectiveness of this intervention. And we did that in different settings and with different populations. So we don't have to keep showing it's effective. We have really good evidence, but we're clearly in the implementation phase now. And partly we're driven that a lot of folks have heard our presentations and want to implement it in their sites. And we are hoping to develop a package, an infrastructure that can be transported to other sites. And that's the phase we're in now, and trying to understand how to make that doable. We're trying to really move forward with this set of tools so that we can export this and help this be implemented more broadly.